So now that we've talked about the root cause analysis, what it is, and what the facilitator's role is, so to speak, and looked at how do we ask questions and developing root cause statements, now we need to figure out what we're going to do with all that information. We've gathered the information, we've narrowed it down into the root cause issues. Now we need to figure out how we can use that information to prevent these things from happening again. We've learned a lot of information in the root cause analysis. I've never participated in one where I haven't learned something. And it hasn't usually been, it's usually been something pretty significant. So how do we use that information to help improve the processes that we're working with every day? And we do that by developing a corrective action plan. We need to develop that plan to prevent the error from happening again. We can't just say, well, we know about it, we're just gonna learn about it and we're gonna educate the staff and we're gonna not do that again. Well, I don't care for education. I think education is fine in its place, and we'll get to that in a few minutes. But education alone is not enough unless you change the process. Unless you do something different, the error is going to continue to happen. And you now have gained some information and learned some very key things about why the error happened. You have a responsibility to help build an action plan that's going to use that information and prevent it from happening again. Historically, the corrective action plan is the weakest link in the process. Why do you think it's hard for people to change? Why do you think there's so much resistance? When you say, okay, now we know that there's a problem, we've identified what the issues are, now we need to change. Why do you think we have, all of a sudden people put on the brakes and say, wait a minute, I wasn't here to help you with that. I was going to help you identify the problems, but now you're asking something different. So they don't have to do more work. That's part of it. Change is particularly difficult for people because it means that they have to do more work or they have to do work differently. And in today's world, people are so busy all the time. They've learned how to get things done. They almost do it by rote. So they can get through things and get them done, and now you're asking them to change how they do that. That's a difficult thing. That's where problems happen. But we really want to take a look at the action plan because, again, unless you make changes, unless you change things, the error is going to continue to happen. We need to target with our action plan, we need to target the root causes that we've identified. We've identified what we feel are the key issues. We need to target the elimination or the reduction of those issues. We need to offer long-term solutions, solutions to the problem. So it's not just a Band-Aid fix. Again, in healthcare, it's notorious. We sit down in a root cause analysis, we barely get into it, and someone says, I know what we need to do different. I know how we can take the change. And I say, well, put that on hold for just a moment. Keep that thought. We really want to take a look at what are the issues first. Then we'll look at what your solution is. But people want to jump in really fast, and oftentimes those quick fixes will fix just that little piece of the problem, but we don't target the root causes. So we really need to make sure that we look at the big picture of everything. Sometimes we need both short-term and long-term solutions. So if you've got a long-term solution that may take a while to implement, you need to do something in the interim to keep the error from happening yet. You can't wait for 3 or 4 months and say, wait a minute, I don't have that policy done yet, or we don't have that new process designed yet, or I don't have that new computer change up and running yet, so it's going to take me at least 3 months. You can't let 3 months go without having some type of solution in the interim. So you may need that Band-Aid fix to help put you in the middle, get it done in the meantime. We need to have a greater positive impact on what they're already doing rather than a negative. And we can't shift the responsibility to another department. For instance, in the example of the feeding tube, we can't say, well, surgery, it really started in your ball court, so it's all your problem. You guys go ahead and fix it and do whatever you need to do and walk away from it. You can't shift that responsibility. People at the table have to own it. People at the table have to take that responsibility and take a look at it. They may need to work together. They need to be objective and measurable and be achievable. And the people who are helping you design the process will tell you if it's objective and measurable and doable. You don't want to rely on memory and vigilance. We're all getting older. You know what that happens. We're also being expected to remember more every day. Again, we have sicker patients. We have higher technology, which has you remembering how to do a lot of different things in order to get the technology to work. Technology is wonderful, but it does come with some problems too. So you're expecting people to learn this new technology, to do all these different tasks, to do things differently, and so you really don't want to expect them in your action plan to have something that remember this or remember that. It drives me crazy when I hear people say, well, if they would just educate the nurses and talk to them, let's just tell the nurses that they have to do the name tag thing. They have to check the name band. Well, how many times have they heard that? They know that. How is educating them going to be any different? It drives me crazy. How many times do we have to tell people something? They know that. It's not the fact that they didn't check the name band. So educating them to check the name band is almost an insult. You're telling me something I already know. You're putting emphasis on education when that's something that I already know. It's an expectation that if I educate someone, then the error will never happen again. I told you all about how to do this, so therefore it will never happen again. Wrong. We're human. Humans have a human factor to it, so I can educate till I'm blue in the face. That's not necessarily going to prevent the problem. There's no way to stop that problem just by telling them how to educate. Also, the way we educate people. Are we educating people in a way that they can learn? For instance, if you hand me a manual, an owner's manual on how to program a VCR, can I do it? Maybe not. I can read it, there's no problem there. I'm intelligent, I know how to read it, but there's a lot of buttons, and there's a lot of buttons that all look alike, and I can push the buttons and it's not working. So is that because I'm stupid that I can't figure this out? No, it's just the way, well, maybe that's true, but it's just the way that I learn. I don't learn things, I learn by seeing things, by seeing how things happen. It's the same thing if I watch a video on how to fly a plane. Are you going to let me fly you in a plane? No. So it's how you learn. So you have to think about the way we teach people. You can't hand them a policy and say, okay, read the policy, now you're educated. You got to look at what they need to be able to learn the task, to learn the process. You need to check to see, did they get it? Did they get the whole part? Or did they put some misinterpretations in there in the way? They're already building in shortcuts before we even finish out the policy. So it's looking at that and making sure that we've looked at all the ways that we educate people. So how do we make sure that the actions are substantial? If we're going to build an action plan and we're going to say, okay, this action plan is a good action plan and we think that it will really help prevent the errors from happening, how do we know that? How do we make sure about that happens? Well, there's a hierarchy of actions that's been developed. And these hierarchies really look at human behavior and what is necessary to help with human behavior. The strong actions are there because they change or redesign the process. This is a strong action. It's really completely looking at it and re-overhauling it. Could be things like standardization. It puts a minimization on reliance and memory. If you standardize everything, it's all the same. Everybody follows the same path. Hard stops. They won't allow you to continue until you do something to correct something. Such physical changes, such as grab bars and non-slip strips in the tub. All of those things are hard stop for physical changes. Forcing functions, such as cash cards. You put your cash card in, you can't get your cash until you take your cash card out. That's a forcing function. You step on the brakes before you put it into reverse. That's a forcing function. You can't put it into reverse until you step on the brake. So those are forcing functions. Simplification, unit dose. I won't ask how many remember before we had unit dose. But it was big change for nursing when unit dose came involved. And much for the better, much for the better. It was terrible trying to count out the right number of pills. Or liquid medications, we had to use a pump and pump so many times to get the liquid medication dose that we needed. Having unit dose come up where it's already decided you take the information doesn't mean you shouldn't check it. But you don't have to worry about all the calculations in that, it's done. It's simplified things quite a bit. There were good reasons for all of these actions that took place. Usually it's because someone got hurt. So we really learned from those mistakes and built these strong functions. Intermediate functions are not quite as strong, obviously, but you can't always have all strong actions in your action plan. It's just not possible. But you want to make sure that you have action plans that at least do something different. Intermediate modifies an existing process. So it's looked at it, it's learned from the RCA, and then it does some modifications to the current process. It helps to detect and warn so that you have an opportunity to get in there and either correct it or minimize the impact on the patient before it gets to the patient. Things such as spell check. It tells me when I spell something wrong, but it's not infallible. If I type in a medical terminology, it's not going to catch that. It's going to say it's misspelled when I know it's spelled right. So it's just one of those things that it tells you that something is wrong, you better take a look at it, but I still have to go correct it. Pump alarms. They tell you something's wrong, but you have to go and check and do something different. And smoke detectors is the same way. They warn you that something's wrong. I smell smoke, there's something going on. You better check to see, is it a fire? And so you have a responsibility, but at least it's warning you, and you have an opportunity to correct it before the damage can happen. Weak interventions, on the other hand, just enhance or enforce the existing condition. So it really doesn't change much, it just kind of reinforces what you already have. That's why they're called weak. But again, you can't have all strong, or you can't even have all intermediate. You may have to have some weak in there as well. But you don't want to have an action plan that's all weak, because it's not changing anything. It's just reinforcing things. Those kind of things look familiar to you? Nurses are expected to remember so much. I'm so glad I'm not at the bedside anymore, because they're just really being expected to remember and be so vigilant about every little thing. We can't put one more thing on top of them without taking something away. We need to be able to help them do their job better. And taking some of the emphasis off by asking them to remember one more thing, or be very careful. How much more careful can they be? They're being as careful as they possibly can. But there's a lot of surrounding circumstances that create some of that havoc. Some of the key elements of the action plan. It doesn't need to be complicated. As a matter of fact, it shouldn't be complicated. It should be very simple so that anybody who picks it up can look at it and know what you're going to do differently and how you're going to do it. It should be very easy to explain. You need to be able to go back to your staff and say, okay, for those of you who weren't in the root cause analysis, we've identified this problem and we need to do this differently, and this is how we're going to do it. And you need to be able to share this document with them so that they can understand how and why things are going to be different. Again, it needs to be realistic. Will it work? And the people who are at the table, who are at the direct bedside, can help tell you that. I can develop a policy and it can look really, really good, but will it work? I don't know. I'm not at the bedside. I'm not doing the work that you guys have to do, so you have to help me there. You need to consider the impact of change and how it will affect other departments down the line. So if my unit has decided that they're going to make this big change and it affects radiology, then we need to make sure radiology is aware of it as well. Or it affects dietary, or any of the other departments, or even another unit. So supposing it's a handoff communication process that we're going to do differently. And so we need to let the other units know that when you get a patient of ours, this is what's going to look different. This is how it's going to be different, and this is why. So we need to make sure that we know that. Anticipate resistance. It's going to happen. There's always people out there that say, oh, that's not going to work. That's not. We've tried something like that before, and it failed miserably. Well, usually we can get around it by saying, well, you know what? This is what's a little different about it, and we're going to try it. Just try it. Just try it on for one day, for 10 patients. Let's just give it a try and see how it works. Often people will be willing to do a pilot or a trial, rather than if you say, well, this is the way we're going to change it, so from this day forward, this is how it's going to be. But if you say, if we're just going to pilot it and then we'll look at it and tweak it as necessary, most people are willing to do that. Most people are willing to give you that chance, if nothing else, to show you that it's not going to work. As we talked about, some actions may take a little while to improve. And so we really want to ask ourselves, what can we do in the meantime? So if we've decided we need to create a new process, we can't leave people hanging. For instance, with the one we just did with the Aunt Rosie fall, we're going to create a process for reassessments. We can't just say, okay, until we get this process done, you guys are on your own. We need to figure out an interim phase, so that Band-Aid fix comes in really handy here. What do we need to do until we get the real process designed that people can feel sure that they're looking at reassessments? For that fall that we talked about, for the ortho patients that we talked about, one of our action plans was conflicting messages and this was the root cause. Conflicting messages and inadequate preparation resulted in the fall. We decided we were going to create a consistent messaging to patients using scripting, so that all the staff were standard in how they were going to tell the patients about how to get up, what to expect, what kinds of things we need to do to get you ready for discharge, but yet you won't fall. We're going to create an assessment for readiness and how while they're able to ambulate alone. So we're going to take a look at what we need to do. How do we know when they're ready to ambulate alone? We may need to bring PT into this process and have them help us, give us some cues, and so we can assess when the patients are able to walk on their own. So those were some of the things. The medication with the computer issue, we decided we were going to create a trigger that will save before the person leaves the screen. So a big pop-up will come up, do you want to save? Or an automatic save would come up. So those are the actions plus that we created for those situations. So what's going to be different? In the ICU, we had some issues with patients developing skin wounds and nurses not catching it until it was on for a little bit. And so we tried to figure out for an action plan, what can we do differently? We have these critical patients. So how can we assess them differently? What can we do differently? And we decided to have what we call walk nurse rounding on the ICU patients. So walk nurses would come up and not necessarily go see every patient, but meet with the nurses to talk about every patient and say, okay, this one is at a much higher risk, and if you can't turn this patient, this is what I would recommend. So getting the expertise from the walk nurse to come in and help us with our assessments. So even though they may not have been able to go in and take a full body look, they were able to talk with the nurses and find out. That was one of our action steps. Another one, we had a patient that developed delirium on our floor after surgery. And she had had surgery, and it was a complicated, lengthy surgery. And after surgery, she was initially fine, but then all of a sudden got really delirious and was acting out and aggressive toward our staff, injuring a staff person. And so we really sat down and took a look at that, sat down with the RCA, drilled through everything. A pharmacist was at the table with us, looking at all the medications they had, pre-surgery, in surgery, post-surgery. Said, well, it's no wonder that you have a problem here, because this kind of medications don't work well together and cause delirium. So now we have a process as a result that the pharmacy will assess the patients with multiple medications. Assess pre-surgery, they'll look down in surgery with the medication reconciliation process. And then post-surgery, if they're on a lot of medications, and I think we said minimum of 6, then they would look to see, is there any medications that could cause problems for delirium or other issues, contracting. So we have a process now. Nobody has to call for pharmacy, it's an automatic thing. So they know if there's so many medications, they automatically come and assess the patients. So those are action steps that are designed to really make a difference. As a facilitator, we need to make sure that these action plans are clear and concise and complete. We can't just say, well, these are great action steps, now go forth and do. We need to make sure that the action plan gets complete. So we're going to assign responsibilities. Now we have, in our facility, we have an overall action plan owner, who's often the director of the unit. But then we have individual responsibilities in the action plan. The owner of the action plan is responsible to make sure that the action plan gets completed on time, or we look at what we need to do to help extend, if we have to extend it, if we have barriers. But we have individual responsibilities who are assigned to take care of these action steps. And those are the people who are closest to the process. And I've always told people, delegate, bring in your frontline staff to help you with this. If it's saying create a new process, I'm not telling you you have to go out and create it. I'm telling you, you go out and gather the people that you need to do that, to create it. But you have the responsibility to make sure it gets done. I can't say it's going to be done by everybody on the unit, because you know what happens when you assign something to everybody? Nobody takes it. So we have to make sure that there is assigned responsibility. We also want to make sure we have an assigned target date. So what is realistic for you to be able to get this done? Month of okay, 2 months, what do you need to be able to get it done? If you don't assign a target date to get it done, it'll get put off. People leave the root cause analysis with the best intentions. They're energized, they've identified some key issues that are new to them that they think, yep, we've got some great solutions for these. They go back to the unit, they have their piece of paper in hand, they get there, everything is in chaos, or things get busy, or things come up. Next thing you know, a month later, they find it on the bottom of their paper stack. So things can get done, forgotten very easily. So what we need to do is assign target dates that keep it out there front and center for them. Let's see, review the literature. Again, you can't review the literature too much, I think. I think that if you haven't reviewed it prior to, you may even learn something in the root cause analysis and you say, what's being done out there? What is the best way to assess behavioral patients for falls? How do we know if we're doing the right thing? Is there something new that's out there that we just haven't heard about? Always happens. There's a lot of things that happen I never hear about. I'm the last to know. So you got to go out and do the literature search. And so you can assign that as well, saying, okay, we have a good action plan in place, but I need somebody to do a literature search and go out there and look to see, is there something else being done that we're missing? And so you might want to do that, especially if it's complicated and this is a problem that you've been dealing with over and over again, you might want to look into the literature. I really didn't like doing measurement. I didn't understand it. I thought it was a waste of time, and I just felt that, we had the action plan, isn't that enough? But really when I started looking at it and started doing more and more RCAs, it's really helpful for us to know that what we're doing in the action plan is effective. We can assume that we've created this wonderful action plan. Why would it not be effective? But we really don't know that. And it's really important for us to be able to test that out into looking at it. We don't have to do a lot of measurement. I mean, it's not something that has to be complicated. But you really don't know that what you put into place, if you're expecting them to change, you need to know that that change is going to be effective. You want to make sure that you measure the process change and not just the fact that you completed it. So we had a situation where we had some stroke patients. We were going for primary stroke center. And we said we had to do dysphagia screening. And so we needed to develop some type of tool to help with the dysphagia screening so that nurses knew how to do this screening process before they took anything orally. So we created the tool and we determined, okay, we created the tool, we're done, right? We needed to determine how effective the tool was. So that's what we had to go back and measure. Not that the fact that the tool was done, but that the tool that we created would actually help us to determine whether or not it was being done. Was it being used? Was it being used correctly? And were we capturing the information and preventing patients from choking? So it's not looking at creating the tool or the process or whatever we've designed. It's how well did it work? How well did it help us? Quality measurement is for learning. It's not necessarily for research. There are a whole lot of rules that go with measurement for research. Quality doesn't have to abide by all those rules. So that always helped me too, that I didn't have to worry about all those rules. What we really need to understand was how effective was the change that we designed. That's what we really need to look at. We're not trying to prove anything other than the fact that if we've changed a process or created something different, we need to determine, did we do a good job? Was it effective? Is it going to make a difference? Or is the fact that we changed something and the way we changed it didn't really solve a problem at all? So an example there is we had, in the ED, we had patients coming in with allergies and allergy bands and stuff. And we had a patient came in at one time that got a dose of morphine and was allergic to morphine. It was in the record as being allergic to morphine. And the patient didn't have an allergy band on. And the EDs typically didn't put allergy bands on. They waited till they got to the floor to put the allergy bands on. So they didn't have that allergy band to warn them to being done. So we decided at that point that we were going to create a process that would have them put allergy bands on patients. So we did that. And I'm getting a little bit further ahead of myself, but we did that in the fact that we had them putting bands on patients that had allergies. So we were measuring that to take a look at it, and she measured just a few patients. We were supposed to do, like, I think 10 patients to determine how effective it was. And we found out it wasn't very effective at all. Only about 10% of the patients were getting the allergy bands that they needed. So she stopped measuring after just a few patients and said, we have a problem. Our process isn't working well. We need to figure out something different. And so she went back to the staff and talked to them, and they said, okay, we need to look at making sure that we check all patients who are going to be admitted to make sure that they have allergy bands on. So it's not just looking for the allergy patients, it's looking at every single patient that's going to be admitted, making sure they have an allergy band on. So they did that. They went back and measured that. And the process was a little bit better. It was 50%, but again, we didn't even get to 10. And she knew that there was a problem. Said, this isn't good enough. We need to really do a better job. Went back to the staff and asked again, why aren't we doing a good job here? What are we missing? So then we looked at the fact that our staff are busy. They're doing a lot of different things. So they determined what would be most helpful is they put a band on every single patient that comes in. They put a band if they have an allergy and the band if they don't. So we have the red allergy band, and we created a band that's orange for the patients who don't have an allergy. And you say, well, why do you do that? Well, because then we know the patient was asked the question. Then we know, and then know upstairs, this patient was identified as not having any allergies. They can guess that if it's blank or if it says no known allergies, but we don't know for sure. And so we tested that. We captured 100% of the patients that were having allergies, got them allergy bands. So it's going back and taking a look at that. It doesn't, again, have to be fancy or that. We don't want to get overloaded with measurement. You don't want to have to do a lot of measurement. So you don't, you want to take a look at what is going to be key. All measures have limitations. So again, look at what you really need to measure. You don't have to measure every little part of the process, but you do need to measure the change, the part of the change. We want to focus on the effectiveness of the change and make sure that it ties to the root cause. So if you're doing a specific measure, especially if it's reportable and you need to report it in, you need to make sure that your measure ties with the key change on your action plan, that you're measuring that piece. So what all do we measure then? There are two types of measures. We have process and outcome measures. Outcome measures tells you, does your process work? Is your process as an overall process, does it work? Are we gathering the results that we need and that we want? It may suggest that there are some specifics about the process that aren't working, but it doesn't give you the details. But it does tell you overall how things are working. Further investigation is necessary, though, if you identify that there are issues. For instance, in P&I studies or falls rates. You're watching it all along, and then pretty soon it's going in a direction that you don't want it to go. It doesn't tell you why. It doesn't tell you what specific part of that process is failing you, but it's telling you things aren't working well. So then you need further investigation to go in and take another look at that to find out, okay, where in the process are things breaking down? That's an outcome measure. It's an overall measure. Your process measures, on the other hand, are measures that look at each aspect of the steps. Good. So your process measure really examines the steps of the process. They're much more specific. They look at the details. Did the process change that we made work? Was it done correctly? Was it successful? You don't want to wait for something bad to happen, so you don't want to have just outcome measures because it won't tell you in a timely fashion where things are breaking down. You really need to have process measures. You really need both of them. For instance, with your process measures related to your P&I studies, you might want to look at your skin assessment tools. That's a process measure, measuring how effective those tools are. Are we picking up the information that we need to pick up? Are they being done and done correctly? The same things with falls assessment tools. All of this information are type of process measures, looking at different steps in your process and measuring to see, did it work? You can also look at transfer criteria, so if you have to transfer a lot of patients back and forth from the ICUs, looking to see, are we meeting the criteria? Looking at that, that's a process measure. So it's really looking at making sure that you have both measures in place, so that you have the outcome measure to look at the overall process, but then you have the process measures to look at the details. So when things start to go in the direction that you don't want them to go, then you have that information and can start looking at things. Again, you don't want to make it too complicated. This is not research. We don't want to make it complicated. We want to make it doable. We're not looking to give people more work. Nobody wants more work. Nobody has time for more work. But it's really important that we do the measure. So we want to take a look at what sources we have out there, especially for your outcome measures. Take a look at what do you have out there for different rates. We have medication error rates. There's tons of measures happening in your organization. And I would bet you money that if you were looking at a specific process, you would find an overall outcome goal in some of those measures. They all provide information for how you can tell if your process is effective or not. There are different ways to collect information. You can do it through chart abstraction. You can do it through observation. Either way gives you information that you need. Either way will be helpful to you. It's answering the question that you need, to tying it to the root cause. What is going to tell you that you're addressing your root cause and addressing the action plan the best? For instance, if it's with pause for cause. If your problem with your pause for cause was that it was, you were questioning whether it was done or not, you can look at that through a chart abstraction and tell if it was documented, because people usually document that. But if you're looking to see was the pause for cause done effectively or done the way it's supposed to be, then you need to do observation. So again, as you're developing your action plan, think about what type of measure will be best for answering this question for you. How will you know that that change is effective? Do you need to do chart abstraction? Do you need to do observation to determine? Either one will give you answers. It's the answer that answer your question about your root cause that you really want to find out. Example for you, again, about how data collection doesn't need to be complicated. World War I, they had a problem with airplanes not coming back, and they were losing a lot of airplanes. And so they had to figure out a way that they could do something different. This is an airplane, by the way. They had to figure out a way that they could do something different to try to understand why are we losing so many airplanes. And they had all these big-time generals at the desk saying, okay, help me understand where the problem is. And everybody thought that they had ideas, but they really didn't know what the issues were. So they had this engineer go out to the field and say, okay, here's some examples on these diagrams. I want you to put on the diagram every place there was a bullet hole when the planes came back. So he was out there working on the planes, and he was collecting information over months of period of time and looking and putting diagrams together with all the different bullet holes on the planes that came back. And so he was collecting all this information and putting it all together, and they were looking at it on a regular basis. But they weren't really learning anything just by looking at the individual diagrams. So it wasn't until they put all the diagrams together after about a month or so and started looking at all the different diagrams to try to understand what the problem was that they determined. This was the final diagram. So then they said to the generals, okay, here's the final diagram. What do you see here? What do you see in that diagram? Besides a lot of bullet holes. So some of the generals thought, well, that means that they're really bad aim. They missed a lot of places. Or then some generals are really technical and said, well, maybe the bullet went over the air curve and did this kind of thing, and they kind of missed certain pieces. But they were all looking at it until one general said, we have a gap here. There's a spot here with no bullet holes. Why do you think that is? These are the planes that didn't come back. This is where they got hit, the gas tanks were. And so once they hit the gas tanks, the planes exploded, they didn't come back. So by studying all this, they shored up this part of the plane, put bulletproof material there, and the planes all came back. So they were able to stop losing quite so many planes and save more pilots as well. So by just looking at a simple diagram and not putting an awful lot of effort into it and not putting a lot of technicality into it, you learn a lot of information. So think about, maybe not this diagram when you're doing your action plans, but certainly think about how you can measure in a creative way, but yet an effective way that can work with you. You want to choose measures, again, that tell you if the change worked. I can't emphasize that quite enough, that you really are looking at your root causes, you're picking your action plan, and your measures all have to tie together. They have to all address the same issues. If you don't target your root causes in your action plan and in your measures, you've wasted that whole hour that you were together. You really need to work to look at all of those pieces. If you've identified some critical issues, you need to address them. You need to have clear and complete measurement plans. You don't have to do a lot of measurement. And some people say, well, how many is enough? And I would say you can do a sampling of people. You don't have to do your 100% population. You can do a sampling to tell you whether or not it was working. And I would ask you, how many do you think is enough? The ER nurse that did her knee bands, 5 was enough, and she knew right away it wasn't working. Something was happening. So how many do you think is enough to tell you whether or not the change is effective? Joint Commission had a 30% rule, that 30% of your total population was a good sample process. You want to make sure that you've sampled enough so that you've collected all the different possible scenarios that could contribute to the error, but yet you don't want to overdo too many. You don't want to have this to be a burdensome task. So maybe, usually what I do is have them do about 10 per month for 3 months. 10 per month of measuring a process. Looking at the process will usually give me that information. Spreading it out over a 3-month period of time tells me, okay, they were doing it here, they knew we were doing it here, so they were doing a really good job. The next month, they may have forgotten a little bit, so I'll catch those. The 3rd month, they forgot about it, so I'll catch those. So it would tell me if my process is sticking. So spreading it out a little bit over a period of time and asking people to do that measurement for that period of time, it's not burdensome. They can easily delegate some of that to have it done, but yet it looks at enough samples. It gives me a sample of 30 patients to tell me whether or not that process looks right. Now, if I have a process that's rarer, I may need to have them look at that a little differently. So rather than sticking to just that type of process, I may need to say, for instance, if it's a surgical process that's only done once in a blue moon, I may need to say, well, let's look at all processes that are similar to that. But looking at enough processes, it will tell you, because you don't want to wait for that once in a blue moon to come around before you measure again. You want to know by the time that one gets there that you've got a problem or you've got a problem solved. So looking at that, how long should you measure? Well, again, it depends. The short-term process change, you should measure to make sure that it's successful, that you've determined that it's successful or not. If it's not successful, I would hope that you would go back and redesign and then measure again. But if you've determined that this is successful over that 3-month period of time, then you can stop measuring. If you've determined that, you know, we did pretty well, but I'm still not confident that we've captured it all, then extend it a little bit further. So it kind of depends on the process that you're measuring and the people that you're working on. If this is something totally brand new, you might want to think about doing some spot measurements later on to make sure that it's captured. Sometimes you can capture that information in your outcome measures. So as you watch the falls rates going along, the change that you made may have affected that. And if you see it going in a direction that you don't like, you can dig into it to determine, is that because of what we did, or we're not doing it again, or is there another problem happening here? So looking at that, setting a threshold that's realistic. Is 100% really realistic for everything? Knowing that we have human error, knowing that there's a lot of things that are contributing, 100% isn't always effective. So asking staff to have 100% isn't going to be realistic. They're set up to fail. So looking more at, you want at least 90%. I would say anything less than 90% is not, I would not feel that that's acceptable, that I've got a solid process. And leave a little bit of room for human error. And again, you want to reevaluate your measurements, taking a look at seeing how they're doing. And if you're not being effective as you're measuring along, stop. Don't keep measuring. I've had so many people that have had, earlier days before they really got to know me, would hand me their measures and say, well, we only did 40%, but we did the measures. Well, I'm going, no. Stop. If you find that it's not working, don't keep measuring just because I told you to measure. We need to take a look at the process and say, okay, what needs to be different? Obviously, what we've designed here isn't going to work. So we want to make sure that this doesn't happen again. What do we need to do differently? You pull a team together and say, what do we need to do different? And then you go ahead and re-implement and remeasure again, making sure that everything is complete and accurate. So with the fall that I talked about in the ortho department, with the assessments not being done, we determined that we were going to have, looking at the assessment process for when they were ready to get up and walk on their own. We were going to do some observations with that to determine was that being done. And then we were going to use the falls rate as the outcome measure. So we were measuring both pieces, both the process step and changing the assessment process and observing that to make sure that it was being done, and then looking at the falls rate to see did we affect the falls rate ultimately. And with the measure of the Medicare patient error, the trigger for reminding, again, we did the observation process. So we looked at to see every time a nurse went in there to do med reconciliation, did that save pop up? Did it work every single time? And then for the outcome measure, looked at overall medication errors.